Good morning, good afternoon, good evening, depending on wherever you are in the world. It's a pleasure to introduce this webinar, and thank you for taking the time to join us for this session. We understand how busy you are all responding to the pandemic. I am Marlo Liebel with the Ending Pandemic in San Francisco, United States, and with CORDS, Connecting Organizations for Regional Disease Surveillance. We are united against infectious diseases, and this is the second webinar in a series that we are holding together with the University of San Francisco. Today, because of the current pandemic we are all trying to respond to, MISITS, the Middle East Consortium on Infectious Disease Surveillance, has organized this webinar together with the Tel Aviv University to address what is the Middle East region doing to respond. And we will hear from a series of experts from the region. And we hope that coming out from this session, we'll have a better understanding of the response, what is working well, and how can we take these examples to be used in other regions and other continents, because CORD's intention is to link all continents under its vision of uniting against infectious diseases. I don't think that there is a need to expand on the reasons for having this webinar. I hope that you will participate. There is a couple of pieces of housekeeping now that I would like to mention. We encourage all of you to present your questions, and for that, please use the Q&A box at the bottom of your screen. All questions are going to be answered after the presentations. When you submit the questions, please include your name, your location, and your affiliation. That's important for the other participants listening today. The other point is if you would want to tweet, please use the hashtag CORDS COVID-19, CORDS COVID 19. The last point is that the session is being recorded, and the record is going to be published shortly in the CORDS website. I think that's it for introduction, and I'm going to turn over now to Professor Coyne.
Thank you very much for Marlo for the introduction, and I will start to present and to introduce the participants, the speakers and the panelists, and I'll start actually to present my colleagues who are here. Professor Hitam Muxen from Tel Aviv University School of Public Health and MISIDS, and who was actually very much involved in the scientific preparation of, and led the scientific preparation of this webinar on behalf of the School of Public Health. And also with me, Sarit Perlman and Jacques Barocas, who contributed a lot and take care of us in terms of all the technical assistance. And actually we planned at the beginning to have much extended group here, and also others all over the world, but now it turned out that most of the participants are dispersed in many places nationally and internationally due to the current situation. So let me just say what we are going to do and to present in the next 80 to 90 minutes. There will be 4 presentations, and after my short presentation, I will invite Dr. Sami Al-Sheikh, Sami Sheikh Ali, Head of Data Management Department at the Communicable Disease Directorate of the Ministry of Health in Jordan, to present the experience of Jordan in dealing with the COVID-19 pandemic. Then there will be the turn of Professor Ziad Abdin from Al-Quds University, who will present the Palestinian perspective related to COVID-19 pandemic. And then we'll have a presentation given by Dr. Yaniv Lustig from the Central Virological Lab of the Ministry of Health in Israel, and from the Tel Aviv University School of Public Health, also on behalf of Professor Mendelssohn and Dr. Orna Moore. And the topic will be, he will highlight the importance of the rapid development and diagnostic tests of the new coronavirus, and the laboratory preparedness, which is so important under the current circumstances. The last speaker of the session will be Dr. Bruria Adini from the School of Public Health here at Tel Aviv University, and she will give an overview on another important topic, and this is the non-medical challenges associated with the various negative aspects of this pandemic. Then I welcome and will be honored to hear the comments of the international panel of this webinar, which include Dr. Dorit Nitzan, who is coordinator of health emergencies at the World Health Organization, the regional office for Europe. Dr. Silvia Bino, he is head of the Southeast European Center for Surveillance and Control of Infectious Diseases, CECIDS. This is a sister network of MICIDS and part of CORDS and ending pandemics. And we'll hear also the comments of Professor Manfred Green from the University of Haifa, who will give his perspective on facing the COVID-19 pandemic. Just to mention that Dorit and Manfred were among the founders of MICIDS 18 years ago. So everything is a long story and successful story, and I will speak a little bit on the history of MICIDS. So then we'll have a session of questions and answers and comments, and as Marlo, Dr. Liebel said and mentioned, they will be collected and will be addressed at the end of the talks, and also the panelists' comments. So I think that now we'll go to the first presentation, which I'll try to give, and the title is MICIDS as a platform to addressing emerging infectious diseases, and I will also talk on and try to review the updated characteristics and the new knowledge in general, global knowledge on the COVID-19 pandemic, and also trying to share some of the Israel experience facing this pandemic. But just first, some words and a little bit on the history of MISIDS. And actually, MISIDS, the Middle East Consortium for Infectious Disease Surveillance, was established in 2002 by health professionals from the academia and ministries of health of Jordan, Palestinian Authority, and Israel, with recognizing that the notion and the germs do not know borders, and with a pragmatic approach, the goal of MISIDS was to facilitate trans-border cooperation in response to outbreaks. And along the years, MISIDS proved to be instrumental platform of collaboration addressing emerging infectious disease like, for example, H5N1 avian flu in 2005, and then the pandemic influenza H1N1 later on in 2009. And then investigation and transmission along the year on foodborne diseases with salmonellosis of a specific target. And then also investigation and on the transmission and modes of prevention of vector-borne diseases like West Nile fever and leishmaniasis, which are common and re-emerging from time to time in our region. And recently, together in a joint effort, MISIDS carried out a large seroepidemiological study on the Middle East respiratory syndrome coronavirus. And now, actually, we are working together to find the best way to improve our understanding and how to address better with our, I would say, capabilities and modest, I would say, support, but with a lot of willingness to help and to work together to address the current pandemic at a regional level. So just to move and give a few key events regarding to COVID-19 pandemic, and just all of us perhaps remember the end of December when there was a first report from China on cases of pneumonia of unknown etiology in Wuhan city in China, and they were associated probably at the beginning with foodborne transmission of a pathogen that was associated with the seafood market in Wuhan city, and this pathogen was found to be a virus, and the new coronavirus that was then actively and intensively spread to other counties in China, and later on to neighbor countries. And from the first foodborne transmission, this pathogen, new pathogen, actually succeeded in being very intensively transmitted person to person, causing already a lot of morbidity. And then he got a name, and the name is SARS-CoV-2. This is the pathogen, and the disease itself is COVID-19. And in another important date is March 11, 2020, when WHO declared COVID-19 as a pandemic. And this is the epidemic curve of the confirmed COVID-19 cases by date and WHO region. These are data true for updated for 31 of March, and we actually speak about almost a million of cases to date. And we can see actually that the first peak of morbidity was associated with China and with the neighbor countries, and then there was a decrease, and everything was actually became a peak of morbidity, extended morbidity in Europe, with the leading morbidity in Spain and Italy, and recently actually the new peaks and new contribution in cases of huge number of cases of COVID-19 in the United States. And these are data regarding not morbidity, but mortality related to COVID-19, data from WHO. And here we actually deal with almost 40,000 fatalities associated with COVID-19, and about 3/4 of them now are in Europe, and the United States now is contributing more and more. But just to see the pace of fatalities, and this is impressive that in about 1 day or 24 hours, around 3,000 or more of new fatalities occur. These actually contribute to an estimated case fatality rate of almost 5% all over, in all age groups and all over the world. But we must keep in mind, and we are already very well aware of a differential fatality rate in terms of related to age, with much higher fatalities in old people and those with comorbidities, and much lower among young people and in children. And if we carry out and draw a comparison by countries, we can see that there is a range of case fatalities in old age groups, and I think that the leading is Italy. We know the terrible data coming from there, and the tragedies that of so much mortality, and then Spain. So Italy around 11%, Spain almost 9%, and France. So they are the leaders, and we actually are at a good situation now with 0.4% case fatality rate. Jordan, as I see here, is also around less than 2%, and we'll hear probably from Dr. Sami more input and information regarding this case fatality rate. Altogether, we have to be cautious and prudent, because it's everything, the denominator, there are confirmed cases and confirmed by PCR. So it's so important to know, and it's so influential, the severity of the cases which were defined, or their age, and the policy of taking and running these PCR tests in terms of those who are tested. For example, Germany has the lowest case fatality rate, and as we may know, there is a very liberal and use of tests, and liberal in terms of all the range of morbidity, from including very young people, and also those with a lot of mild cases. So now a little bit of the COVID-19 Israeli experience. I must say that the response in Israel was very prompt, and I would say intensive, even aggressive response after the first classes of disease in China, and when the disease has been spread to the neighbor countries, and that was associated with a recommendation to avoid non-essential travel to China, and then the use of home isolation for 14 days for all those Israeli residents coming back from China, or coming back from Thailand, Hong Kong, and Singapore and Macau, travel and warning, then related to Italy, when the morbidity increased, and mortality increased there. Again, home isolation, and then all these measures were associated with a lot of stopping of international travel, and it culminated with the restriction of flights from all over the world, closing borders, and home isolation of those returning in general from abroad. All these has been taken as prompt and aggressive measures to try to avoid or prevent the first imported cases to Israel. and that was what was the policy, to try to do the best in order to postpone as much as possible the occurrence of the first cases. But this occurred, and that was in February 21, 2020, when the first imported case of COVID-19 was identified in Israel in a traveler from the Diamond Princess cruise ship, who was diagnosed while being in quarantine at the Sheba Medical Center. Now, moving from this, I would say, timing event, there were more and more imported cases, and then the measures were intensified in order to not only to prevent but to contain local transmission, Israeli transmission, local transmission, secondary transmission of COVID-19. And the main target was strict social distancing, and this is actually I would say the target. And this measure and preventive step includes a lot of drastic interventions, like avoiding large gatherings, school closure, university closure. We teach actually, and we use remote learning. This is perhaps one of the, I would say, the positive aspects of if there are, because we are now forced to use this important method of teaching, and that will have at least a positive impact in the future in terms of teaching, long distance teaching. And the recreational establishments were closed, reducing entry to the public space, closing non-essential stores, and finally, actually, coming to a very close stage to complete lockdown, and for example, reducing personnel at workplaces to 15 at 30%. And of course, all these measures have a big economical, I would say, negative impact, but we have to live with this until we'll be sure that we are on the right track. And I'll come to this point in a few minutes. So this is all these measures went together with this intensification of screening, actually, and testing subjects with respiratory symptoms, with a large case definition, but all of them being symptomatic. And this is the increase in the number of tests taken and performed. And from one lab, which was, we'll hear about, it's the establishment of the tests at the biological lab at the Tel HaShomer Medical Center, and then now many labs in Israel are carrying out the laboratory testing based on RT-PCR, and we have a lot of confirmed cases. And together with the extension and expansion of testing, which actually now reach about 5,000 to 6,000 per day, we have a lot of new identified cases, and this is actually the cumulative number of cases of laboratory confirmed patients with COVID-19 in Israel. In March 22, this is 2020, but this is the number today, 6,200 new cases, and here is actually the number of cases per day. So there is an increase in the number of cases, but what is still a sign that tells us that we are still in controlling and containing at least the occurrence of cases of severe cases, and of those who will need intensive care and mechanical ventilation. To date, most of the cases are mild cases, and or moderate cases, and only about 2% are severe cases, and with about to date also it's 29 deaths. That this is the number today. Every death is a sad thing, but that's life and that's death. And most of the fatalities occurred in old people. And again, we are, and these are the curves, the severe cases and the cumulative death, showing actually that the increase is in numbers in these severe cases, which are of much concern regarding the capability of the medical centers and facilities to cope and to offer the right support to maintain this low case fatality rate. These numbers and this I would say pace of increase is it's actually of I would say a moderate pace. So we are controlling. At this stage, we are well controlling the epidemic, and this is probably the result, and this is our assessment and the assessment of the Ministry of Health, that the early response and very aggressive and response was actually we see here now the preventive and the results actually which are positive in terms of low segment of severe cases and of fatalities. And this is just one of the last slides which show the geographic distribution of the COVID-19 patients. First of all, it's the distribution by age, and we can see here that most of the cases occur in were identified in the 20 to 40 age group, and then here actually is the geographic distribution, with Tel Aviv in the center of Israel and Jerusalem districts leading in the new number of new cases of disease. And this is especially due to towns and cities and settlements in these districts of the Ministry of Health, where there are crowded communities, especially ultra-Orthodox communities with the highest incidence rates of disease, probably due to the difficulty in maintaining and in imposing the social distance and also objective conditions of an excess of crowding. And here, and these populations are probably the target for the immediate, even more intensive interventions. And I would just want to touch the current challenges that we have to address actually, and under these circumstances that I described in terms of morbidity and mortality in Israel. And the target is to try to gradually return to work and to routine life after the big shutdown, to avoid further economic damage and reduce the general population stress in the same time. And we actually, to reach this stage, we have to be sure that we do everything to reduce the SARS-CoV transmission, and will manage to prevent potential new epidemic waves, such that such various and additional waves of epidemic waves occurred with the 2009 pandemic, and even with the very, very dangerous and first pandemic with so much, with more than 30 million deaths, and that was the 1918 flu, Spanish flu pandemic, where this kind of new epidemic waves can occur. So this is something that we have to take into account and to try to prevent. Now, how do we prevent actually, and how can we be sure that this can be or be confident that this can be attained? It's just to combine preventive measures and disease surveillance to bring together and to continue to maintain as preventive measures social distancing, enhanced person and environmental hygiene, use of protective masks, and avoid large gathering and crowds. And in terms of surveillance, which is so important to know where we are in terms of morbidity and mortality, we have to intensify syndromic surveillance, to have all these huge screening of temperature measurements to detect and isolate COVID-19 cases. And in addition, we think that very soon we'll have to look at the mirror image of morbidity and to look at potential increase in the natural acquired immunity of the population by running thorough surveys to extent of this acquired immunity at the population and individual level. All these will actually, we are confident, we hope that this will reduce the risk of continuous transmission of the SARS-CoV, and hopefully we'll move from an epidemic stage, stage to an endemic stage along the years. And an important thing is to, because I'm not sure that in the Palestinian Authority and in Jordan, we are on the same page in terms of prevention and containment. We have to continue collaboration and intensify collaboration with the Palestinian Authority and in Jordan by all means to contain further transmission of SARS-CoV in the region, and okay, and the last slide propose MISIS as a platform for cross-border collaboration and to do now what we've done in the past, and this time in order to address the COVID-19 pandemic. And what we are planning together is to design educational programs and panel discussions via webinars, like we are doing today, for health professionals in Israel, the Palestinian Authority in Jordan, and other course networks on topics of high relevance to the current crisis, and they will be delivered by leading epidemiologists, physicians, lab experts, and public health professionals from the two countries in a co-teaching approach. They may include updates on the level of morbidity and mortality regionally, surveillance methods, lab-based and syndromic, clinical management of COVID-19 cases, infection control, sampling and testing strategies, non-medical aspects of the crisis, and other aspects. A parallel education program is intended for the general public with special emphasis on the most vulnerable populations in the region who may lack access to accurate information and prevent exposure to fake news, which are so common today. And I want to thank you for your attention. Now, as we decided and we spoke, we'll have the questions by the end of the speakers and the panelists' presentations. And now I want to invite Dr. Sami Al-Sheikh from Jordan, the Ministry of Health, and our colleague and long-term, lasting and term collaborator within MISIS to give his talk on the Jordan experience facing COVID-19 pandemic. Please, Dr. Sami.
Thank you, Dr. Danny. I will share my slides. Okay. Okay. As known, at the end of the January, WHO declared that COVID is a public health emergency of international concern. And on 11th of March, it was declared as a pandemic. In Jordan, until the 1st of March, we haven't any case. The first case was in the 1st of March with a case with the travel history from Italy. And as per yesterday, the 1st of April, we have 278 confirmed cases and 5 deaths. From the beginning, Jordan began to create our national preparedness and response plan for COVID-19. We use the WHO guideline. Our plan was formed from 8 panels. In my presentation, I will focus on the technical panels. The third one with the surveillance, rapid response teams, and case investigation, and the point of entry, national laboratories, and infection prevention control. As per WHO for transmission scenarios, we think that Jordan now we are experiencing now in the third scenario. In Jordan, we have a national epidemic committee. This is a multi-extensive Minister of Health. The crisis now, and there is a consultation on the prevention and curative measures, and they are working to update the plan. Our plan is continuously updated by the committee to specify the measures and actions. For the
We're having difficulty hearing.
And technical pillar, when are talking about the surveillance, rapid response teams, and case investigation, we
Dr. Sami, let's see if perhaps we'll, through Laura, we can fix the problem, because we don't hear you so well. And then we'll come back to your presentation, and perhaps we'll move to, is it okay? Maybe we'll try again, but perhaps we'll move to Dr. Ziad and come back to you if everything is proved to be fine. You hear me, Dr. Sami? Dr. Sami? Okay. Let's, Dr. Sami? Okay, Dr. Sami? Okay. I think that we'll move to, if it's okay with you, Dr. Ziad, we'll move to your presentation, and in the meantime, we'll try to fix the connection with Dr. Sami in Jordan.
It's fine with me, yes. May I start or what?
Yeah, you can start. Go ahead. Thank you.
Thank you, Danny. Hi, everybody. I would like to present the Palestinian Authorities' response and preparedness for the COVID-19. Okay. Let me give you some background information about the total population, the Palestinian population. Approximately it's 5 million. Divided between the West Bank and Gaza, 3 million in the West Bank and 2 million in Gaza, of whom 70% have refugee status. In terms of geographical size, the West Bank is approximately 3,500 square kilometers. It is similar to the size of Delaware, while Gaza is 365 square kilometers, twice the size of the District of Columbia. But unfortunately, no more than 30% of the land is inhabited over there. In terms of age structure, it's a very young population. From 0 to 14 is around 1/3, but the blessing in disguise, those who are above 65, they constitute only 3.5%. I'm afraid there is a mistake there. It's 15 to 64, approximately 60%. Next, please. Now, this is the case map for the West Bank and Gaza, according to the Palestinian Ministry of Health website, which shows actually the number of cases. Next, please. In terms of male to female ratio, it is more or less similar to China. Okay, it's 59% males to 41 females. And the data suggests probably men might be more susceptible. I really don't know. I cannot really swear to that. However, in terms of distribution between the West Bank and Gaza, it is 10% in Gaza vis-a-vis 90% in the West Bank in terms of number of cases. Next, please. Next. Now, in terms of age group, you can see this is also, the data is coming from the Palestinian Ministry of Health. Okay, next. You could see the following. Does coronavirus have a striking age-related disease? From the pattern I see, I'm not really sure we can say that, because some people claim that it affects the people who are above 65 more than others. I don't see that here, okay? Next, does it reflect something about lifestyle vis-a-vis biology? Probably that is the case, because people, they tend to move quite a lot, and contact probably might be the cause of the spread of the disease, okay? Now, it's important to know the following, next please, that the data collected so far on how many people are infected and how the epidemic is evolving, next please, are utterly unreliable. Given the limited testing to date, many cases are being missed. So we don't know whether we are failing to capture infections by a factor of 10 or even 100. I'm not really sure. Next, I'm going to talk about what the Palestinian Authority guidance that have been issued. Similar to many other countries, they tighten border controls with its neighbors. They put limits on crowd capacity. They close more schools, colleges, and universities, and temporarily close restaurants and coffee shops. The Palestinian Authority's approach is really based on containment in order to stop the disease, okay? It's through social distancing. I believe that their goal is to buy time, slowing down the spread of the disease, so it really, to sort of not to burden the healthcare system in the Palestinian Authority, which is very poor indeed. Next. In the West Bank and Gaza, we currently do not have a full understanding of the spectrum of illness, meaning that we don't know how often the disease will manifest as a mild, severe, or fatal cases. Next, and there are two types of tests urgently needed. One is to determine whether a patient has an active ongoing infection, and the second is to determine whether a person has ever been exposed to the disease. Both types of tests will be critical to controlling the virus. Next, please. What are the current challenges? Unfortunately, we don't have the needed surveillance or case detection or the diagnostic capabilities. You know, the WHO, they keep on telling us test, test, test. Unfortunately, we cannot afford that, so we tell them to rest at home. Our health system needs more or major investment in training, in laboratory capabilities, in personal protection equipment, and case management of the infected cases in healthcare settings. We keep on talking about hospital ventilators, which we have very limited number indeed, but we are extremely good at verbal ventilating our frustration at the authorities. So strengthening the Palestinian preparedness and response capacity is really strengthening the capacity of all regional countries. And we hope to see that soon. Extraordinary times call for extraordinary measures. Well, I'm really going to talk about the social distancing here, which has been recommended by the WHO, and many countries have adopted that system. I want to say the following, that human beings do not really have a limitless capacity for self-imprisonment, because it really, you know, just numbs your brain with boredom and really affects your physiology as a whole. And I'm not really certain whether those who are their immunity being compromised, they are at a greater risk than those who suffer from the psychological factors due to depression and anxiety. And as you know, that depression and anxiety are kissing cousins. Next. So what are the coping mechanisms we need? People, they don't like uncertainty. They like to be in control. They like to be in control of their lives. And if that is not the case, people tend to go into depression. I contacted no less than 20 households, and I asked them, how do you cope? The majority of them cited religion as a key factor in terms of a coping mechanism. Next, please. There are two take-home messages from the short presentation about the epidemiology of the disease in the West Bank and Gaza. Without a vaccine or cure, we have no control over the duration of infectivity. Number two, we have only limited control of the opportunity for transmission, giving the ability of the virus to transmit before symptoms appear, undermining the effectiveness of case isolation. But there remains, next please, a lot that we could do to minimize the opportunity, the transmissibility, and susceptibility. Finding the index case and rapidly tracking and isolating their contacts are really key to stopping the fire before it spreads. This requires serious preparedness. How does this outbreak end? The most uncomfortable answer would be, next please, I believe it will become an egalitarian virus, i.e. everybody will have it. Two pandemics are never the same. Thank you for listening. Next, the final point, questions for discussion. Next, please. Is there more than one strain? And if so, is there a diversity between the different strains of the virus? Number two, do individuals become mildly ill for a period of time and then worsen suddenly and dramatically at a later stage, i.e. is it biphasic? Number three, does COVID-19 spread in communities as well as in hospitals? And number four, how do we address mental health and poverty arising from our measures? Those questions I pose really for the panel. But finally, I want to really mention this. Why the disease is not spreading in third world countries in a similar fashion to Europe and the United States? Is it because of the PCG immunization? I'm not really sure. Thank you for listening. I'll stop here. Thank you. Back to you.
Thank you very much, thank you very much, Dr. Ziad. Now, I just got a message from Dr. Sami. Okay. Dr. Sami probably doesn't, it's not able to hear us or to give his lecture.
I can see you now and I can hear you. Do you hear me?
Yeah, but yeah.
The connection is
yeah.
so
Okay, so Laura will share the slides.
Yeah.
Okay. Now, just a short question. I don't know what's, and I apologize, but Dr. Nitzan, she told us that she has to go to a meeting, a WHO meeting there. Dorit, can you stay with us another?
I can stay until 1:45.
1:45. Ah, okay.
I mean 1:45. It's 1:45 your time.
That's fine. Okay. So,
yeah.
So okay. Thank you very much. So, Dr. Sami, please, if you can give now the presentation.
Okay. So I will begin from the beginning because you didn't hear anything. So in Jordan, the first case was in the 1st of March. It was a case with a travel history from Italy. As per yesterday, 1st of April, we have just we have 278 confirmed cases with 5 deaths. Next, please. From the beginning, Jordan began to prepare a national preparedness and response plan for COVID-19 using the WHO guideline, and it was formed from 8 pillars. And in my presentation, I will focus on the pillars which concern with the surveillance and the point of entry, national laboratories, and infection and control. Next, please. Upon the WHO for transmission scenarios for COVID-19, Jordan, we think that we are in Jordan now shifting from the second scenario to the third scenario because we experience in Jordan clusters that in a certain geographic area. Next, please. In Jordan, we have a national epidemic committee. This is a multi-sectorial coordination body chaired by His Excellency Minister of Health, and the committee meet on a daily basis and consult on preventive and corrective measures and update the plan. The plan it's continuously updated by the committee to intensify measures and actions. Next, please. Now I will talk about the technical pillars for the third one for surveillance, rapid response teams, and the case investigation. From the beginning, we do a case definition for COVID-19 and it was updated upon the epidemiological situation. We create rapid response teams and we created at the central level and at the governance levels. We have more than 30 rapid response team in the governorates. This rapid response team investigate the cases and do contact tracing. Also, an active surveillance for COVID-19 from pneumonia cases admitted to the ICU in the hospital, in the public hospitals. We test randomly all this pneumonia cases of atypical pneumonia cases for COVID to see if it is distributed in the population or no. Also, we create a hotline about the corona and for inquiries and to report any suspected cases. Next, please. We have in Jordan 3 hospitals, three hospitals were identified for quarantine, isolation, and case management. And also we have another 4 hospitals were identified for screening and testing. And if it is positive, it will be transferred to the main hospital in Amman. Certain hotels were rented for quarantine to the Jordanian coming aboard for 14 days. Next day, please. For the point of the entry from the beginning of January, or from the 28th of January, we began to do thermal screening of passenger upon arrival. We do coordination with the Civil Aviation Commission to apply the health measures at the point of entry. We do create a quarantine area designated at the Queen Alia Airport for any suspected travelers. Also, we distribute risk communication materials with health messages on COVID-19, and also travelers were informed where to seek medical support in Jordan if they develop symptoms. On 16th of March, an extreme measure have been taken by imposing all arrivals to Jordan to 14 days quarantine. And on 17th of March, all a travel ban was issued except for cargo. So all travels was stopped. Next, please. For the national laboratory, we have our national public health laboratory in Amman have the full capacity to do molecular testing for rapid for real-time PCR. At the beginning, only the national public lab was designated for COVID-19. Then after that, we approved for two additional private laboratories now, and now we have another two private lab to do the testing, and also the Jordan University and King Abdullah Hospital and the military hospital now have the kits and they can do the test. The WHO protocols for COVID-19 testing and diagnosis are adapted by the National Public Health Lab, including genetic sequences and management biological materials. In general, the public health lab tests about 300 to 600 specimens per day with a detection rate about 2.5%. Next, please. For the infection prevention control, from the beginning, we also begin the refreshing training for infection and prevention control for the healthcare workers. We do share the WHO guideline for infection prevention control with healthcare workers, and also we provide the healthcare workers with the PPEs, we distribute risk communication materials, and also we distribute the risk communication materials to travelers, including the I-form to be filled by the passengers with clinical symptoms. And also we have well-trained medical teams in each hospital who were assigned to manage COVID-19 confirmed cases. Next, please. For the, we do an assessment and to identify the needs for beds, equipment, and materials. We have two plans, the plan A and plan B. The plan A, it was put, there is two main hospitals. The first one, the Prince Hamza Hospital in Amman. It is exclusively designated to manage only confirmed cases of COVID-19, and it covers the middle and south region of Jordan. And King Abdullah Hospital, it is partially designated to manage confirmed cases, and it is from the north. Next, please. The plan B is that all public hospital now they are ready to designate 10 to 15 beds to manage confirmed cases if it is necessary, if the number is increased and the main hospital cannot cover. And also all private hospitals are requested to designate at least 2% of their beds to manage confirmed case COVID-19 cases. Also, an additional hospital, it is put in the plan to be assigned to be COVID hospitals if we pass to scenario 4. Next, please. I will talk a little about the situation in Jordan. Next, please. Here we see the cumulative COVID cases in Jordan, and the total number until yesterday it was 278 cases, and we can see that it is a slight slope is horizontal. We hope that there is no sharp increase as in other countries. Next, please. And this is the epi curve of the cases. As you see, the first case was in the 1st of March. We have a silent area about 2 weeks. Then the cases begin to appear. In the 15th of March, we have the 12, and we have the biggest one, or the peak. It was in 26th of March, and after that, the cases begin to drop. Yesterday, we have just 4 cases or 6 cases. And above we have in the red the distribution of the cases of the deaths, and we have 5 deaths. Next, please. For the by age group, we can see that we have cases is mostly at the youth age, young ages between 20 and 58. The cases above 70 or 69, 60 to 70 is low, but we think that this because the population here is more young, and we haven't a lot of people above the 70. But in general, we can say that it is 20 to 55, all, most of the cases. And in general, in this group, the symptoms is more severe. Next, please. If we see the distribution by sex, we see that there's no difference between the sex. It's about 51% in male. Next, please. And here, if we see the distribution by governorate, we can see that the most of cases is in Amman and Erbil, and these two cities, they are the biggest cities in populated in Jordan. So for that, we see that the cases mostly there, and in Erbil, we have a cluster from a wedding that was there. And because that we have a lot of cases there in Erbil. Next, please. If we see the distribution of cases by nationality, we can see that 88% of the cases were Jordanian. We have only 12% non-Jordanian, mostly from 12 from Iraq, 6 from France, 4 from Lebanon, 3 from United Kingdom, 2 from Philippines, and so on. Next, please. Next, please. Yeah. We have in Jordan, no, can you go back? Okay. We have in Jordan 5 clusters. The first cluster, it is from a wedding in Erbil in the north. We have about 47 cases, which represent about 70% of the cases. And also we have another cluster of 21 cases from a building in a certain area in Amman. And we have another cluster of 17 cases related to a nurse from a hospital in Jordan. And we have 11 cases from a hotel related to a Canadian tourist. And we have in the hospital in 3 cases in one hospital was related one to other. Next, please. Here, the distribution of cases among the patient situation. We have most of the, we have 36 of the patients were cured now. We have 234 under treatment, and unfortunately 5 deaths. And we have 3 foreigners who are leave Jordan immediately after they are tested. They were asymptomatic but were tested and were positive. And they want to believe that this was from the first cases. Next, please. Next. In conclusion, we can see that there is a stability in the number of cases recorded during the current week. 28% of the cases are asymptomatic and were detected through the active surveillance and tracing contacts. The most affected age group is the youth between 20 and 59 cases, which represent about 66%. The elderly represent only 5.6%. Cases were concentrated in Amman and Erbil. The death rate is 1.8. We have 5 cases. 4 of them were aged between 77 and 83 years. And finally, 88% of the cases are Jordanian. And we have dealt with 5 clusters. Next, please. Thank you. That's all.
Thank you very much, Dr. Stamli. And there will be a question by the end. I am reminding that by the end of the session, I'll just propose now to have a small change in the program. In any case, we can go until 2 o'clock. It has been extended, and because the presentation was a little bit longer, and including my presentation. So, what we'll try to do now is to invite Dorit Dr. Dorit Nitzan to give her comments and address what has been presented so far and any additional comment, and then to invite Professor Manfred Green because both of them have to leave to go to meetings. And we'll continue then with the other two presentations, and we'll have Dr. Bino address everything by the end of and before the end of the speakers and the lectures and before the questions and answers. So this is the plan, and apologize for the change, but let's try to do it. Dr. Dorit Nitzan.
Thank you. How long do I have?
I think that 5 minutes, but maybe
5
more.
minutes? No, 5 minutes is great. Yeah, 5 minutes is great. Thank you so much. Thank you, Professor Cohen, Professor Mohsen, and to all of you, my dear friends. It's so great to be with you and to see how the message continue kicking after so many years. And also thanks for all of you, all the speakers for now, and for the hard work you're doing, and really bringing the norms and standards and the guidance that were created so quickly by our teams to the ground, to the people, to save lives. So as you all said, we are running after a small virus that connects us all while we are all in physical disconnect. And it's amazing to see how we can connect during these times and make everything, like Bruria said yesterday, you know, all the borders are open now, just like the virus uses it. So for us, it's very important for WHO to work systematically in an organized way and to tackle everything from all directions, because we have so many issues that are not only in the health field per se, or in the health systems per se. What we see, first of all, that countries are different, and are different in the context, different in the scenario where they are now, and also different in the way they monitor what they do or what they actually do. Just to say what we recommend as WHO, and you all mentioned the containment and mitigation. So we recommend a blended approach. We never let go of the containment. And the containment, this is the public health flag here. This is the thing that the public health professionals lead in countries and should lead if they don't do it. This is the place where we said test, 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 and not rest, 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 but test, test, test. We mean as much as we can, as you can, according to the context. What is important is that all suspected cases will be identified and isolated from all contacts. It's very important that all their contacts will be quarantined in a respectful manner, but to really put kind of a little invisible line around those who have the virus or suspected to have the virus. Testing helps to identify it and actually to pinpoint who we do. We have different apps now for following the contacts and trace them or notify them. And many countries are approaching, either they're doing it themselves, like Israel, or others that go with different tools that we recommend. So after this testing, isolation, and quarantine, it's very important to treat. And it's very important to understand that and to do what we see now in Spain, in Italy, in Germany, in other countries where the mass, it's really massive. It's very important to minimize the care in the hospitals and to ensure that those that need hospitalization get it in a really quality manner, but protecting mainly the healthcare workers. And healthcare workers, we say, not only physicians and nurses, also cleaners, also other people that are working in those hospitals or institution settings, and in any other place that need to be care for patients. So it is very important to take care of those that need to be hospitalized. The others should be left under whatever is right for the society. In some societies, we have to take those who are isolated to other places, just like Israel does with in hotels or other places where they can be separated from their contacts, possible potential contacts. Others can stay home if it's a small household and they can separate, but everything has to go case by case and to monitor them. And then when we do that, and when we see that we got to the point when the infectivity rate is above 1, or really above, we see it in some countries really higher up above 1, that we see that we lost so-called control. We have to harness everything we have in order to stop transmission. And here we come and we see these so many measures, the non-pharmaceutical measures that are being taken, and the huge impact they are going to have on health, or they are already having on health. And that's also not good. So we know that we need to find the balance, and the balance needs to be fit into the context of the community, of the country. And there is no one size fits all. Therefore, I was very happy to see that our strategic preparedness and response plan, the WHO one, is used, and it has to be tailored to the country-specific one. And there, when we know what the strategy, we can then advise when to go to what we call transition phase. Transition phase is the phase, we don't call it exit anymore. Initially, we used to say exit. We say now, let's do containment and mitigation. Let's do suppression. That's very important, because you'll never be able to go into a transition phase if we do not do the containment measures. This will not work, because the minute we'll open, everybody will go out, everything will come back. It will see another wave coming up. So in order to avoid it, we need to continue blending this in the right way. And in this transition phase, we guide countries, and we are starting now in 1 or 2, as slow as we can, to guide them how to take it off, how to go back to life, and how to be able to see. But this we do when we see the infectivity rate is really under 1, then we can really move. But we need data. And here I come to the most important issue for us as WHO. We are sitting on tons of data, patient by patient. We get reports from the countries, and we go patient by patient, and our people are looking and putting it in. But the data is, what we get out of the data is as good as what we get in. And what we get in from countries is so different. The denominator is different. In some countries, the denominator is different because they test only the people that are severely sick. They don't test the mild cases. Big mistake. Mild cases are those that are going to drive the pandemic on and on. The mild cases are the key cases that will keep spreading it. So we don't get those. Then you think that the death fatality rate is so high, and the case fatality rate is so high because you lost the denominator. Then we have problems also with the surveillance system, not the surveillance, the lab ceiling. In many countries, they don't have the lab abilities, or they have a very minimal set of capacity, how much they can do per day. Then they have they are lagging behind and queuing until you get the message that you are positive, you're already wild in there, and then things can go wrong. So the ceiling is also a problem, and also because of the ceiling, we don't have enough information on really how many patients are there. Then we have problems with the numerator. Death are attributed to COVID-19 when there are other causes of death. And go so on and so on. So it's not easy to work in this uncertainty. And the thing is that we are working in huge uncertainty. A new virus, new host, I mean, the host is old, but new host for this virus, that the host doesn't have any tools to deal with it. And then information that is so lacking and so not well harmonized. So I think all in all, I can tell you how hard it is for each and every country and community to work. And we have to do our best. So thank you very much. I hope I didn't speak too long.
Thank you very much. Very, very important comments and this tailored approach for countries of much importance and to be understood. Thank you, Dorit. Thank you very much. And now I invite Professor Green if you will tell us your comments.
Okay, thank you very much, Danny, Professor Cohen, and all our friends. Dorit is gone, I see. Hi, Dorit.
I'm here. I'm here.
Oh, you're still here. Okay. For those who don't know, Dorit is my wife and I'm her husband. Depends which way you look at it. We don't see each other much other than on the screen. She's in Copenhagen and I'm here in Israel. I'd like to, and also I want to mention Professor Ziad Abdin, which I don't see on the screen. Ziad, are you still here? Yeah, I see it. There I see something on the screen. Hi, Ziad. Ziad obviously is one of the founders of Methods, and it's great to see you again.
Nice seeing you too.
And I enjoyed your presentation very much, and also Dr. Sami, and of course Dorit and Danny and the others. I'll actually be quite short. You're going to cover all the issues relating primarily, obviously, to COVID-19 and the issues of dealing with it. And I can just say that I agree with everything that you've said, because these are the important issues. I think just in framework of Methods, I just want to say a few things that already Ziad has raised, Dorit has raised, and so on. First of all, the data is very important, but the data is related to collaboration. And I think that I think the expression of saying we've got the virus here that's actually, in a strange sense, it become our enemy, but it's joined us together. So we're basically fighting a common enemy. And this is the time to join hands, all of us, and help each other. And I think this is really what we need to be doing. So I think this is an opportunity for all of you to say, what do you need? What do you need from each of us? So that if we can support you, you may have something. And it's a two-way thing. For example, we was told we may need to, we should be supporting the people in Gaza and the West Bank, but the people of Gaza, I understand, have a factory who are supplying masks one way or the other to Israel. And I think there's a factory in the West Bank as well, where we are trying to get into an arrangement where they will help us there. So, and I think for tests, we should be so we need to really make it clear to each of us, what do we need and how can we help each other? And obviously WHO is a great agency for promoting this and bringing us together. So Ziad, Sami, all of you, tell us, what do you need? And we really will work very hard to try and respond to your needs. And I'm telling you now, we're going to ask you for help as well, because we're all in this together. The other, I'll give you just one issue now that's being spoken about in Israel about masks. There's now a recommendation to wear masks, and I know there's a variable views on that. I myself am not entirely convinced, and I think WHO is not really being convinced yet. But I think that it actually does something that, Ziad, you made a very good point about what people do under these circumstances. And I think we need to encourage these cottage industries. What would be better for families and so on to start producing masks at home and sell them? In other words, produce them for sale. I have a feeling there's going to be a market for them. So I think these are the kind of things that will keep people busy, but also will bring them some income. So I think we need to start thinking of little startups like that, where in fact people can actually benefit from what's going on. The other issue is something that's not spoken about enough, although I know WHO has been emphasizing it, and that is that we, under the stress of COVID-19, we are missing out to some extent on the other illnesses. People are getting sick just as they have been all the time. And we know now that people are delaying coming to the emergency room. They're having difficulty getting access to care. We may be finding that our vaccination rates are going to drop for routine things. So I think, again, that's another issue that I think we should talk to each other about. How are we able to maintain that? How do we get a message to the public that if you have chest pain, it's more important to get to the emergency room than to concern yourself about worrying about getting COVID? And we should work out ways that these people know that they are protected and they can get access to the care that they deserve. You've probably heard that hypertension is thought to be a risk factor, at least being investigated for this. We would guess for COVID or for complications of COVID-19, we would assume that if hypertension is well controlled, then that would no longer be a big problem. So, you know, these are issues that we really must not forget. The world goes on, even though COVID-19 is around with us, and probably, as Ziad mentioned, it's going to become virtually, become a universal virus, and we'll have to work out ways to cope with it in the future. I think that the final thing that I just wanted to say, go back to, was this question of sharing data. I think that we should work out a way that we can share data of good quality data. And I'll tell you, we have trouble accessing good quality data. So I'm not saying somebody else does and somebody. Let's look at the ways in which we're doing. And I think if we can even submit proposals together to get assistance in actually improving data collection, and most important, data analysis. They're accumulating data and they're not able to analyze it. As Dorothy said, they get a huge amount of data they need. I don't know, I'm speaking for WHO. I'm not sure that that's true, but I think we need help in actually analyzing the data in the way that we want. So I think that these are some of the projects that we could talk about. And let's plan for the future, the transition phase, and what's going to be happening next year, because we really have to start planning for the future and make sure that everybody is secure, safe, happy. And I really hope that this unfortunate event is really going to bring us much closer together in the Middle East. Thanks very much.
Thank you very much, Professor Green, Manfred, and for the so valuable comments, and for reminding the mission and the vision of, especially of MISITS, has been again established 18 years ago. Okay, thank you very much. And now we'll come back to the short presentations, which became long presentations, and try not to take the example of the first presenters, including myself, and be shorter in actually a little bit shorter in your presentations. But go ahead, Yaniv, Dr. Yaniv Lustig from the Biological Lab, National and Central and Center Biological Lab of the Ministry of Health and Tel Aviv University, please.
Hi, thank you, Danny. I'll really try to keep it short. So hello, everyone. In the short time I have, I would like to tell you about the laboratory preparedness in Israel's Central Virology Laboratory for COVID-19 diagnosis. I would just like to mention that in addition to myself, both Dr. Oran Erster, the head of the Molecular Biology Unit, and Dr. Michal Mandelboim, the head of the National Center for Respiratory Viruses, contributed significantly to the work I'm going to show you today. But first, I'd just like to say a few words about the Central Virology Laboratory. So our lab is part of the Ministry of Health and contains several national reference centers, which are also connected to both the WHO and the ECDC. And now in the past 20 years, the lab acquired extensive experience with viral outbreaks like measles, mumps, polio, avian and swine flu, and also West Nile virus. Our lab has played a significant part in confronting these outbreaks, and also in the transfer of data and technology to other labs, including those from the Palestinian Authority and Jordan, and also by participating in several joint meetings. So going back to COVID-19 diagnosis, I'm sure many of you have been introduced to these pictures before. So COVID-19 suspected samples arrived to our lab in their hundreds every day in triple packages, as you can see here on the left side of the screen, in white boxes. And these swab samples, which were inside these plastic containers, were opened up in a BSL-2 hoods. Now, our processing protocols included 3 steps. In the first step, we removed a portion from each swab into a lysis buffer, which inactivated the virus. This was done under enhanced BSL-2 conditions in an isolated room. Now, once the virus has been inactivated, we extracted the nucleic acids on an open platform and moved to identify the SARS-2 RNA sequence by real-time RT-PCR assay. Now, in order to be able to keep a quick sample handling, to keep a sample handling to report turnaround time, which would be pretty quick, and to process urgent samples in addition to the online work, we implemented 2 automatic platforms for extraction. This allowed us to have a flexible workflow. So the small volume platform allows extraction of up to 12 samples in a turnover time of about 35 minutes. This is the MagLead platform, while the high volume extraction, which is by the MagnaPure 96, can extract 96 samples in about 90 minutes. Now, after testing several lysis buffers, we chose the EasyMag lysis buffer, which is usually used for inactivation of nasopharyngeal viral samples. And what we found was that this lysis buffer can be used interchangeably for both platforms. This allowed us to keep a flexible and adjustable workflow. And as can be seen on the slide, have a turnaround time from sample handling to results of about 3 hours during the daytime and 14 hours during night. This usually occurred when the samples arrived either in the evening or late at night. Now, after the extraction, we established the real-time PCR for COVID-19 detection. We based our protocol on the assay, which was initially developed by Korman et al. From Germany, which detects 3 genes in the SARS-2 RNA sequence. These 3 genes, which are shown in the slide, the RDRP, E, and N genes. Now, as can be seen in the right panel here in red, you can see that the E gene seems to offer the highest sensitivity. And because of that, we use the E gene as our primary screening tool and initially test all the COVID-19 suspected samples using this E gene platform. Now, in case confirmatory tests were needed, both the N and RDRP tests were used. And in addition, we also used another confirmation using commercial tests developed by the BGI company, which we saw, which was highly sensitive. Now, once our pipeline for COVID-19 diagnosis was established, we started to transfer our knowledge to other labs, both in Israel and the Palestinian Authority. Several hands-on teaching days on COVID-19 testing were performed. Our molecular biology unit held these visits during February for several diagnostic labs, both in Israel, East Jerusalem, and the Palestinian Authority. I just received these pictures from our partners in the hospital in Ramallah, showing one of these visits to our lab. And now, after all these participating labs and other labs in Israel implemented COVID-19 testing, we decided to distribute an external quality assessment. At first, what we did was to generate positive and negative samples and coded them from A to J. We, of course, tested these samples in our facility and then sent these EQA panels to all the laboratories involved in COVID-19 clinical testing. After receiving back all the results from each laboratory, we checked their performance. And once the test was approved, we were able to certify each lab who successfully passed this panel. Now, as you can probably see on the left panel, this EQA panel contains several samples for COVID-19, in addition to some other samples from respiratory viruses, which were used as a negative control. On the table on the right here, you can see that overall 30 labs participated in this EQA panel, and that several different assays for COVID-19 detections were used, and that all of these, all labs successfully passed the EQA and were given a certification to perform the COVID-19 diagnosis. And the last thing I would want to tell you is a little bit about, to summarize COVID-19 diagnosis in our lab. So as you can see in the graph, We started testing for COVID-19 on January 24th, and until March 10th, our lab was the primary lab which diagnosed most tests in Israel. Now, the first COVID-19 patients came from the cruise ship from Japan, as Danny mentioned, and they were detected on both February 21st and 2 days later on February 23rd. And the first patient in Israel was an Israeli traveler from Italy, which was diagnosed on February 27th. And then the first endemic infection in Israel was detected a few days later on March 2nd. After this time, the number of COVID-19 patients and also the number of tests rapidly increased and reached a few dozen cases which were detected every day and a few hundred tests which were performed every day. And starting mid-March, many labs have started testing COVID-19, and currently our lab primary function is to develop better tools for molecular and serological diagnosis, in addition to the detections of samples from the population which are not in isolation, doing a screening test, and also from urgent cases. Overall, more than 30 labs in Israel are now testing several thousands of samples each day, with the hope that this capacity will help in the fight against the expansion of this outbreak. So with this, I would really like to thank the organizers for inviting me to speak and all of you for listening.
Thank you very much, Dr. Lustig. And again, actually, the Center Lab, the Virological Lab, demonstrated such a rapid response, a successful response to this new emerging event and extraordinary event as the lab has rapidly reacted with the other emerging events in the past. Thank you very much. And now I would like to invite Dr. Adini to give her lecture on these very important aspects of the non-medical burden of COVID-19 pandemics.
Thank you very much, Adani and Yaniv. Oh, I wanted to ask you to allow me to share my screen. So thank you for doing this. I would like to thank all my colleagues that so eloquently described the Israeli, the Jordanian, and the Palestinian struggle to overcome the extensive damage that is being caused by COVID-19. We could see from your talks that there are many commonalities in this joint venture to contain the virus, and I would like to highlight one specific comment by vital component of this struggle that both Professor Ziad and Professor Manfred referred to. When we delineate the major stakeholders in this COVID-19 crisis, we mainly refer to three main actors. We refer to the healthcare systems, the emergency medical services, the hospitals, community clinics, laboratories, and so on. The second actor are the governance systems, the national, the regional, even the local. And then, of course, we look upon all the international bodies, foremost the WHO, and we heard Dorit when she was describing this leadership, which is a global leadership. But there is another vital target population, which is crucial to facilitate almost any directive that we would like to implement. And that is the public, as individuals, as families, as communities. We sometimes tend to consider them as a challenge, or sometimes even worse, as the problem. But they're actually a vital component of the solutions. As studies have already presented, including the most recent publication by Song and his colleague, which published an article which was just came in last month. They talked about the resilience as an important element to achieve community engagement. And this is what we're asking the public every day. We're telling them to comply to varied measures such as home quarantine or isolation or lockdown, social distances, and so on. So we need to ensure the resilience of the populations in different levels, including the individual level, which means the ability of each person to adapt successfully to significant challenges that threaten their well-being. We're talking also about the community resilience, which signifies the ability of the community to cope with different stressful conditions and recuperate. And we're also referring to the national resilience that addresses issues such as societal sustainability and strength. All of these three elements are crucial in order to maintain trust in the leadership and subsequently to comply with the measures that are being conveyed to the civilians. So as monitoring the levels of resilience during this crisis, we initiated in the past 2 weeks a study to measure the current status and compared it to a baseline level, which we measured in 2018, which was in this region a relatively quiet and uneventful time. So what we discovered are some interesting findings. As we expected, you can see the levels of concern and as well as the stress symptoms actually increased during the COVID-19, which is something that we can expect in comparison to the baseline level. But what we saw concerning the individual resilience, that resilience were actually lower compared to the pre-corona virus period. In comparison to that, and in contrast, the level of the community resilience rose. We can see the baseline in 2018, the average was 3.11, while now during the past 2 weeks, it has risen to a higher level, and all of these results are have been found to be significant. The national resilience did not change during this period of the COVID-19. So how can we actually explain these results? We can understand the decrease in the individual resilience because the public are under stress and they're looking at the different risks. And when we look at the risk, and these again, these are results from over 600 people, which represent the different layers in the Israeli society, we can see that the risks that most threaten or are perceived as the highest threats by the publics are not the health risk. It's not the coronavirus. It's actually the political risk as well as the economic risk, because so many people in Israel, over 1 million people have already lost their job temporarily or even long term. And only the third perceived risk is the health risk and the security risks. So we need to relate to all of these feelings and perceptions of the people. The community resilience, our explanation, and this is something that we have also seen in previous research, the reason that the community resilience has actually increased is because the people are looking for support systems. For example, this is something that they looking to see if their neighbors, even through the technologies, not by face-to-face meeting, what information they can give it, what the local leaderships. One of you mentioned religion, which is very true, and so on. So we need to take this into consideration and provide the support that is so much needed by empowering the population, by explaining to them how they can help, even when they're directed to stay at home, disconnected physically from their routine support systems. For example, we can relate to them how they can help stay connected with others that so badly need this social contact through all the technologies, even the ones that we're using right now. We need to relate to their concern of their financial situations. Otherwise, they may tend to disregard our directives in an attempt to continue to generate some income. And Manfred's idea of letting them, for example, have initiate making homemade masks is a wonderful idea. Now, there are additional steps that we can implement relatively easily in order to impact on the resilience of the populations. And this is another study that we conducted just in the last few days. Again, within a population of over 500 people through internet panel, that they represent different layers of the Israeli populations. We exposed those participants to a 6-minute video film, which was actually done very quickly by Magen David Adom, the Israeli EMS. The video film displays very simple information: what the coronavirus is all about, what are its symptoms, what is the required behavior, and explaining why this is so important. When we compared the levels of the knowledge, as well as the level of perceived knowledge, the feeling of being protected, and the resilience, what we found is a significant increase in all of these 4 components after viewing the film compared to the level that was presented before that. So the level of the knowledge, and even more than that, to a great extent, the perceived knowledge, as well as feeling protected, were all found to be positively related to the level of resilience. I would like to highlight another element. In order for the public to comply, they need to trust the authorities that convey those directives. What has been done in many societies today is to totally frighten the public by presenting devastating predictions. Thousands in the communities are going to die. We will not have enough ventilators to provide intensive medical care. The police and maybe even the military will forcibly implement the lockdown. These are very scary things, and fear was the main element that was actually conveyed. But what we learned in the past from previous research is that fear does not enhance the compliance. On the contrary, it raises the level of denial, and thus we may achieve the opposite behavior of what we're actually aiming for. What we need is an efficient risk communication campaign that will present the facts while not ignoring such predictions, but that simultaneously empowers the public, gives them hope by stating, for example, we're studying the coronavirus. We have no doubt that we shall successfully overcome it, but only if you're a partner to this effort. You can contribute to the health and safety of your father, your mother, your neighbors, and others by staying at home. We know from studies that solidarity and community cohesiveness rise during crisis, and a feeling of responsibility towards others will achieve much higher compliance rates, which is so crucial in this time. And this brings me to the last point that I would like to relate to, and that is, who is responsible for managing the crisis? So we know that the coronavirus is a public health event of international concern, but it's not the only concern. There's also the economic concern, the societal one, and at times even a political crisis. And as such, this crisis should be managed and coordinated not only by the healthcare systems administrations, but rather as a holistic challenge involving many other stakeholders, such as ministries of finance, economy, security, and more. Furthermore, global sharing of information and knowledge, as was previously said by the previous speakers, sharing the knowledge, studying the data and how to analyze them and understand the consequences, and collaborating even more closely, that will enable us all to combat the current hazards. We need to do this together. And I believe that all of us, as scientists, as in researchers, in the framework of message, should conduct these studies together so that we can identify the varied cultural and societal diversities and their impact on our population's resilience, and we will all highly profit from such collaborations. Only by centralizing and collating the added value of our working together can an effective management be achieved, and we will be all together able to bounce forward. If the coronavirus does not recognize the borders, why should we? Thank you.
Thank you very much, Dr. Adini, and thank you for the invitation for collaboration, which is so needed. This is something that we'll want to do together within Misits. Thank you very much. And now I'd like to invite Dr. Silvia Bino, one of our distinguished panelists. Dr. Silvia Bino is part of the director of the Southeast European Center for Surveillance and Control of Infectious Diseases, CECIDS. And as I said, this is one of the networks, as MICIDS is, and is part of ending pandemics and of courts. So, Dr. Bino, please bring your comments and your perspectives. Thank you for attending the meeting.
This webinar, and it was quite interesting to listen to all presentation. I lost a part of your presentation, Danny, so because I couldn't connect, but I would like to start from Ziad presentation that he said about the testing, test, or rest. So we have to combine them. And coming from a country that have not many resources, I would like to say that we have to do our best to follow the WHO strategy, but at the same time, we have to know, because in this pandemic or in this outbreak, let's say, we are facing something which we didn't face before. Usually in bigger outbreaks, we didn't test everybody. We don't test everybody. So we take it for granted and we take prevention measures immediately. While in this one, we are recommended to test everybody. So it's becoming a mass testing, let's say. And as Dorit said, you are losing, based on your testing strategies, sometimes you are losing the people who are asymptomatic, or you are losing people who are with mild symptoms. So we have to combine the strategy, and maybe we have to work together about testing strategies in our countries, because I listen also very to your presentation about the lab capacities, about PCR capacities, which is a very good tool for reference labs. But what we are going to use for testing in the field and what we are going to use for reference laboratories. So are we going to move for field testing? And HIV has taught us about this kind of testing. So we have to learn from different strategies already used in different infectious diseases. So we have to learn from HIV how they move to field testing, and this was one of the key, and still it is one of the key prevention strategies, because those field testing for HIV and recently also for hepatitis, viral hepatitis, those are key strategies in terms of prevention. So is COVID going to be one like this in terms of testing strategies in the field? And now a lot of emergency use of those testing are going out. So maybe we have to work with each other and with Israel especially in terms to get some advice in such terms, because this is a key issue. And then what comes after testing? Because testing is just a method. What comes after testing? If I test negative and I'm a very close contact, I'm going just to go out and stay with my friends? No, I mean, we have to build even resting strategies when the testing is not enough. So I think even those experiences we should share with each other. And I think this is quite important to learn, because the whole world is learning actually right now. And then I'm coming and how to build a containment. Because I can talk from Albanian government that took very drastic social distance measures. So before discovering our first case in 8th of March, we closed schools and we banish the public gathering, like, you know, opera, concerts, whatever. And then after the first case, we closed all offices and restaurants. And after the week, the first week, we are in a lockdown. So people do not move, do not work. And I mean, we have some rules in terms of doing the shopping and how the shopping is organized. So it are very, very drastic measures. They cannot last forever. And meanwhile, we have been trying to build very strong containment strategies for contact tracing, isolation, quarantine, whatever. And maybe we could share experiences, because it's not so easy to do the quarantine or especially the isolation at home, because you have to care for the people. And this is doing case by case, but might be some sharing of experiences about that could be also could be something profiting the whole community and our countries. The other thing that I'm going about the data that Manfred raised, and I think how the data are collected from all these different points, from the testing, from the isolation and quarantine strategies, so from the surveillance and from the control, both data from both parts, from you know, from early detection and from the control measures. All countries have vast amount of data, but we don't know how they are collecting those data. And sometimes we might have data related to the disease, early detection and surveillance, but data about the control are sometimes lacking. The special data about the isolation numbers, about the quarantine numbers, how the isolation and quarantine is followed. So sometimes those data are lacking, the number of contacts related per patient, et cetera, et cetera. So I think as a very, very important point, how those data are collected. And the most important, how those data are analyzed. And how those data are analyzed, we can have a common group of experts that advise our countries and help on data analysis. So, and then we should work together on this and build, you know, further recommendations, improve our daily work, etc. Because those are data coming from the ground. This is all I can say, because I don't want to take your time.
Thank you very much, Silvia, for the very important comments and suggestions. And I think that the courts and the ending pandemics with the structure and with the these combined with the many networks all over the world, we can actually try and attain these targets of collaboration in terms of data sharing and joint management and analysis of data and the exchange of experience. Thank you very much, and we'll take, I hope that we can propose and take these suggestions, steps forward. Thank you again for the comments, and now we will take, I think, unfortunately, we are very close to the end of the session, and but we'll try to take one or two questions and give answers, and all those who send their questions, they will get answers by email. But now let's try and have one or two questions and provide answers to those who kindly asked us questions.
So, hi everybody. Thank you for sending so many questions and good questions. So we selected two questions that these points were raised in several questions. So the first question was asked by Professor Tami Shochat from Tel Aviv University. Tami is the former director of the Israel ICDC. Tammy asked, how do you explain the great variation in the percentage of severe cases between countries?
Okay, so who maybe, okay, first I see Manfred here, and if you would like to answer the question, and Manfred?
Sorry, I'll give it just, I'm obviously, I don't know more than Tammy does, so I'll give what I believe is, I think that one of the things that people are not aware of, or those who are not using epidemiologic data, and Tammy, I'm not talking about you, I'm talking about the public, on a general basis, is that we recognize that there is a lag time. So what you can see, for example, is you'll see countries, including Israel, by the way, where we have very low mortality rates or case fatality rates, and then they start increasing. Well, basically, it's not unexpected, unfortunately. If you look at the other data, and I don't, it's something that we don't maybe talk about enough, but we've got a lot of people on ventilators. And tragically, some of those people are not going to come off the ventilator. In other words, they're not going to survive. So what you're actually seeing, basically, is the deaths that you're seeing now on average are the people who got sick maybe 3 weeks ago. And they became sick, and then they deteriorated and went on to ventilators and so on. So there's this lag period, and you need to look at that lag in the different countries. And in fact, even if you look at a country like Germany or South Korea, you'll see that their case fatality rate keeps going up. It doesn't mean that the situation is deteriorating there. You're just seeing basically what happened a couple of weeks ago or 3 weeks ago. And the same with China.
Okay, thank you very much for the answer. And there is another question.
Yes, there's a good question from Dr. Yara Dahal, Nature Palestine Society from Palestine. She asked, how can your platform help the Palestinian Authority control the issue of the Palestinian workers in Israel that are moving freely and might cause the spread of the disease in the Palestinian Authority? So I think this question is referred to Danny, Ziad, and Dr. Sami together.
Okay. Dr. Ziad, you can.
Danny, you may start.
Okay. So the question, how can this be stopped, or?
How can methods help the Palestinian Authority control the issue of the Palestinian workers in Israel that are moving freely and they might spread the...
Yeah, I think that in this case, what I would suggest, and this is something that we have to take into account, is to use the same approach and test. Try to offer actually testing while they are here, and they have to be actually the approach can be and should be as it is for those who are actually for Israelis, because they are part of the working force here. The question is if they are symptomatic or are not symptomatic, and actually the same approach has to be that is conducted with the Israeli cases or suspected cases has to be taking and conducted with the Palestinian workers, I would suggest. Any other comments?
That's the logical answer, actually, we can give. There isn't really much we can do about it.
Yeah.
And maybe I'll just make one comment. I think going back, we're basically one area. I think it's an artificial way of thinking that there is Palestine and Israel and Jordan, that they are kind of hermetically different. We need to recognize that we're one area and we need to help each other. So the crossing of borders and so on is a sense of, we'll do for each other what each other will do for themselves. They'll have, the spread of the disease will go everywhere. So it really won't make matter. As Ziad said, it's not, the borders won't make any difference anymore. What we need to do is help each other to cope with it.
Yeah. Okay. I think that we'll keep the other questions, and we'll offer answers by email. And unfortunately, we are running out of time. And I want to maybe we'll put the last slide. I want to first of all to thank all the speakers and the panelists. And just have a slide that, okay, oh yeah, okay. Yeah, I want to close actually the session and the webinar by thanking to the organizing committee that actually we have worked for, I would think, the last 2 months, and many webinars, many TCs, and came to this this webinar today. And our colleagues within MISIS, and I would like just to mention Sai Husseini, who is the MISIS executive officer. He was with us here, but okay, and especially the lot of time investment and help from the University of San Francisco, the group led by Professor Laura Chu, and of course all our friends there and colleagues. And I want to thank to Dr. Maro Lieber from Ending Pandemics for actually his input, and for this initiative of having these webinars organized for the networks of coding under Ending Pandemics. And many thanks for all those who attended virtually the meeting, and thank you and goodbye.
Goodbye.
Thank you.
Goodbye.